Welcome, everybody. We're so glad to have you here today. I'm Susan Brooks. I'm the current president of SCIC. Apologize for my lack of formality. I'm recovering from surgery for a badly broken leg, so I don't look my best today, but I wanted to share an opening invocation that comes from the Jewish tradition that I thought was appropriate for today. Source of all being, creator of all life, may your goodness find its way into the hearts of all your children. May those who wield power do so with the balance of wisdom, justice, and compassion. May those who feel powerless remember their intrinsic worth and also act with the balance of wisdom, integrity, and compassion. May we all feel called to action based on the injustices of racism and see ourselves not as enemies of one another, not in struggle with one another, but as human beings created in the image of God, connected to one another's well-being. May all of us come to acknowledge that may all of us come to acknowledge the racism that is pervasive in our region and our nation. May we commit to sitting down with one another in honest dialogue, opening our hearts and compassion to one another, bearing witness to the pain and fear of one another, even if, and especially if, the other looks and seems to be so different from ourselves. May we commit to joining together in acts of justice that will bring about equality in education, economic opportunities, law enforcement, and judicial proceedings. May each of us come to understand that ultimately my experience of freedom, justice, and peace is inextricably linked to the freedom, justice, and peace of every other person in our county and city, our country, and our world. May we open our eyes to the invisible lines of connection that unite us, and with clarity of vision, continue to work for a world where every person's life is valued, cherished, and loved. Amen. I'd like to next introduce Melia Islam. She is the executive director of the South Coast Interfaith Council. Melia?
Thank you. Thank you so much, Susan, for that beautiful invocation. And good afternoon, everyone. I want to welcome all of you to this, our second program in a really important series that we've been working on this year, which is the SCIC Dr. King's Dream series. And this series really focuses on the issue of justice and racism and how all of that is inculcated and manifested in ways that we don't often realize in various factors in our society, in various genres in our society. We had a great program last month that focused on this topic within the framework of the educational system. And today our focus is within the healthcare system. So as you know, the topic that we'll be focusing on today, understanding and addressing racial disparities in healthcare. And so today I have two really amazing women, these powerful women who will be our presenters today as we talk about this really important issue within our society. So without further ado, I'd like to go ahead and introduce them so that we can have time for them to share their knowledge and their expertise in this in this sector. So one of our first speaker is Dana Sherrod, who is the Birth Equity and Racial Justice Manager with the Public Health Alliance of Southern California. At the Alliance, she leads a series of racial equity initiatives with governments, with hospitals and health systems, and most notably with Cherished Futures for Black Moms and Babies, a multi-sector hospital quality improvement initiative to reduce Black infant and maternal health inequities in Los Angeles County. Now, in previous roles, she spearheaded the launch of a statewide mental health advocacy and prevention program for Black women across California and has championed land use policies to improve and build environment in Los Angeles neighborhood of color. As the granddaughter of sharecroppers and civil rights activists, Dana has committed her personal and professional life to pursuit of health, of gender and racial justice with and for communities of color. She serves on the Los Angeles County African American Infant and Maternal Mortality Steering Committee and is on the board of directors for the Institute of Public Strategies. She holds a Master's of Public Health from San Jose State University, and in her free time, which clearly she must have so much free time, in her free time, She loves reading, singing, learning new hobbies, and watching movies with her husband and their 2 young daughters. Our second presenter today is Dr. Deepjot Singh, or she also goes by DJ. She is an established and highly skilled physician with over 20 years of experience in OBGYN. She grew up and went to high school in rural New Jersey and received her undergraduate degree in psychobiology at UCLA. She obtained her medical degree at Chicago Medical School, with most of her rotations at Cook County Hospital, which subsequently influenced her to apply and complete her residency at the Women's and Children's Hospital, USC LA County Hospital. She furthered her education with an executive MBA at the USC Marshall School of Business, which led her to understand the need for the intersection of leadership in various industries, communities, businesses, and medicine to truly understand how pervasive racism is in our society today. She has worked to educate systems of she has worked hard to educate systems on disparities and health equity, and has received numerous awards for patient care throughout her career and services. She has a passion for advocacy in equity, education, and communication to promote well-being by dismantling racism that exists in medicine and society. She currently works and lives in the South Bay with her husband and children, and this is really cool. And she's very proud of her oldest daughter, who just graduated from Howard University College of Medicine and started residency in OBGYN in Chicago. So it's great how the circle kind of completes itself. So we are so honored and we're so thrilled and we are so humbled to have both of these amazing women with us today. So without further ado, I'd like to give the stage to them and have us start this important discussion today. So thank you again so much for joining us, and we hope that you'll enjoy this program.
Thank you so much, Milia, and everyone from SCIC. It is so wonderful to be here. I'm going to just share my screen and give me just a moment. I have the very unique pleasure that I get to work with Dr. Singh, what now feels like on a more regular basis through our work and Cherish Futures. And it is just such a privilege to not only work with her through the work, but also just to call her a friend and a deep ally. So very honored to share this space and time with her in particular. So I like to start by just giving a little bit of introduction and context for who I am, so that as I'm speaking and sharing, you all will have an understanding sort of where I'm coming from and the lens in which I speak. So I like to introduce myself by just sharing my name again is Dana Sherrod. I use she, her pronouns. I identify as a Black Christian woman who also is a mother, a wife, descendant of enslaved people stolen from African lands. I'm also, as Milia shared, also the granddaughter of civil rights activist and sharecropper. So I also like to think that this work, this advocacy and activism work is just in my DNA. I'm also native to Los Angeles, grew up in an upper sort of middle income neighborhood. What's interesting is the area where I grew up was actually previously redlined. And I'll talk a little bit about that today. I also am the Birth Equity and Racial Justice Manager with the Alliance, which I'll introduce in just a moment as well. And just had the very distinct privilege to work for the last decade in my professional life and in my personal life around issues of racism, policy change, system change, both within the context of working with government and with now through Cherish Futures with hospitals and health systems. And so I really deeply believe that we each have a unique and important role to making sure that we are creating a just future. And so I'm going to invite you into that today. A little very, very brief context about the organization that I work for, which is called the Public Health Alliance of Southern California. We are a coalition of the 10 health departments here in Southern California. So you can see sort of all of the different jurisdictions that our members cover. And collectively, they have a statutory responsibility for about 60% of California's population. So very large swath, and I feel very honored to do this work. So in our time together today, we really, our goal is really to make sure that folks are able to leave with an understanding of the impact of racism and specifically what that looks like in healthcare, taking action, understanding ways to be involved. I'm going to spend a first little bit by just sharing some context. We'll have a breakout group. We'll hear from Dr. Singh. And because I grew up in a Black church, I very much believe in like a call and response approach. So throughout, as you're able, would love if you could use the chat box feature, thumbs up, the reactions, whatever way to actually be present and engage with us in the space. A couple of things that I also like to call out because I know most of us in here are committed to making change. And sometimes, we're just really not even barely scratching the surface on so much context. And so, sometimes we leave and we don't have closure. And I just want to call it that it's okay to leave and not have a sense of closure. This is a lifelong journey, even for myself as a Black woman. I am still always learning, always growing, always discussing. So this will be a journey. And of course, just a few other agreements as we're in our shared space is to listen for understanding and also to speak from your own experiences without shaming, of course, or attacking and discounting, which I don't think would be a concern in this space, but always good to put it out there. So I also just really want to just kind of elevate this current moment that we're in. And this conversation really is so timely because 2020 was, sort of what I like to think of as like the great awakening for a lot of folks. And so because of all of the multiple crises that we're, I'd say, still going through, the moment that we're in demands action and accountability. So of course, obviously we're hopefully on the tail end, but still in the midst of the COVID-19 pandemic, which actually disproportionately claimed the lives of Black folks, Latinx, and Native Hawaiian Pacific Islanders, both across the country and here in California. Of course, after the murder of George Floyd, we're also witnessing, a nationwide reckoning on racial justice. And really what I would consider to be a very historic moment, and hopefully, like I said, a transformative moment. So today, like I said, it's very much just the very beginning, what we like to think of as dipping our toes in the water. And my hope is that this zeal that we've seen kind of throughout 2020 is not just really a footnote where we're kind of lulled back into passiveness, but something that really ignites and sparks a real change. So I want to just start by sharing a little, I'm going to share a brief story with you all, if that's okay. I want to share the stories of both Dr. Shalon Irving and Dr. Susan Moore. Dr. Irving was an epidemiologist at the CDC, and she had 2 master's degrees and a dual subject PhD. She pioneered a lot of research about, things like structural inequities that make people sick. And she passed away just very shortly from complications of after having her daughter. And Dr. Susan Moore, which I think folks have become familiar because her story's been circulating in the news at the end of last year, but Dr. Moore was a physician and she died last year of COVID. And in her hospitalization, she was talking about some of the conditions, the treatment that she received, being ignored, not being listened to. And what's so interesting is that both of these women were highly educated, had good insurance, high paying jobs. And yet the underlying connection in their death, although they died from different causes, the underlying root was definitely racism. We know that it's not just access to healthcare or insurance that determine our health and our health outcomes. It's really the conditions in which we live our lives. So I'm going to talk a little bit about that. So I, of course, work in the field of public health. And so we look very much at the context of which, like I said, people live their lives. Where do they experience, their work, their play, their prey? Where do they spend their time? And we think of these as the social determinants of health. So it's the conditions where people, are born, where they grow, live, work, and age. And they include the factors that you can see across the spectrum here, from, your socioeconomic status, your education, the neighborhood where you live, the rest of your physical environment, your social support, and access to healthcare. And these circumstances actually are really driven by the distribution of money, power, and resources across our community. And so just what is so interesting is that when we think about the big picture, you can start to see how there's a lot of room for variation in people's experiences, which ultimately influence our health. So I thought I like this graphic, and my colleague and I use this often in some of the trainings that we do, because most of the time, we kind of think that it is only our behaviors or health behaviors, such as do we smoke, do we exercise, do we drink alcohol, that really influence our health outcomes, when actually, researchers are actually telling us that your zip code plays a bigger role in determining your health outcomes than your genetic code. So you can see somewhat of a breakdown, and there's some disagreements and different proportions of, which elements really have a larger impact. But what I find so interesting is that our physical and our socioeconomic status, I should say our physical environment and our socioeconomic status, determines close to 50% of our health outcomes. So it's really important to think about kind of where we live, and like I said, how we, the spaces in which we move every day. So many of us, really have been taught to believe, or we just assume that kind of where folks live and why we're so separate in where we live is a matter of choice. But when we actually take a deeper look into the history and how we became so segregated, we actually see that the segregation that still very much exists in communities today, all across America, is very much a matter of design. So if we want to address health inequities and the differences in, access and community resources, we have to ask ourselves a couple fundamental questions. So to me, I think we need to think about and ask ourselves, why are our communities so segregated, and how did they get that way? Why are the resources different in different communities? And why are there differences in who lives in which communities? So I love this video. We use this very often. It's a video narrated by George Takei, and it's called The Tale of Two Zip Codes, which I think gives a great explanation. So I'm going to go ahead and play it, and let me know if for some reason the audio doesn't come through. Give it just a second. Let's try this again. Of course, now it doesn't want to work. One more time.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-ville, less than 1 mile away. There's so many ways. One of the ways is that Deb is a single mom. But here's the thing. On average, residents of Beeville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Beeville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow. We lead. We are building the power to make health happen in communities across the state. We are coming together to build one California, a smarter, more inclusive and equitable state that creates health and opportunity for all of us. Join us. To learn more, visit Building Healthy Communities.
So I love that video, and also just the narration, of course, with George Takei is also pretty epic in my mind, but such a great description. And so, he touches on in the video sort of what has happened that has caused us to have such different, starkly different neighborhoods. And so, there's a couple, there are a couple bills or pieces of legislation and practices that I want to highlight that we have seen contribute to the segregation that exists today. And something I didn't include in here, which I wish I had, but I'll drop the link when I'm finished, is there is a map of Los Angeles County, and it is a dot map that allows you to see where different folks live based on their race or ethnicity. And it is fascinating to see how incredibly segregated we are by both race and class. So I definitely want to talk just a little bit about the history of redlining. And I'm not sure, I can't see the chat. So curious how many folks, just by raise of hand, if you're on video, how many folks are familiar with the practice of redlining? I see Miss Winnie and Ronald with their hands up, Sada, Milia, Stephen. That's good. So quite a bit. I think it's such an important piece of history to talk about because, again, it has contributed to why communities are so vastly different. So I mentioned, a moment ago, that the residential racial segregation we see is not accidental, but it really is a matter of design. And as I said, redlining, the impact of redlining is really one of the main drivers. And so redlining refers to a practice of the federal government in the 1930s, where they rated neighborhoods to help mortgage lenders determine which areas of a city were considered risky. So the Federal Homeowners Loan Corporation, which was a federal agency, created color-coded maps, and they actually evaluated 239 cities across the country for financial risk. And so the areas that were predominantly white and were separated from, minority areas were given a green color. And the green areas had homes that were often deed restricted, which meant that they could not be sold to folks of color, even, for as long as that was in place. And the areas in different parts of the city that had more people of color were given a red distinction, which meant that it was not safe to provide loans. So the practice of redlining, along with a lot of other segregationist housing policies at the time, still have, had tremendous impacts then and still have tremendous impacts today. So I have some snippets of the actual HOLC documents, which describes different neighborhoods. This one is a description of the redline neighborhood of Watts in Los Angeles. So you can see here it says that it contains one of the largest concentrations of Negroes in Los Angeles County. There's also many Mexicans and Japanese residents. You can see the document goes on to talk about substandard construction. They talk about slum conditions. And so this is how they would, determine that it was not safe to provide home loans. So subversive racial elements. In contrast, this is a map of Bixby Knolls, which is a neighborhood in the Long Beach area. And so Bixby Knolls was afforded a green grade, which was the highest grade. And you can see that it says this neighborhood was highly deed restricted, and that racial protection was provided in perpetuity. So that meant that it was creating safe havens to keep the neighborhood predominantly white and keep folks of color out of the neighborhoods. And so sometimes when we do these trainings or we have these discussions, folks will say things like, well, that doesn't exist anymore. It was so long ago. Things are different now. And what's so interesting is that the impacts of these policies, and I'm going to talk about the GI Bill too in just a second, but the impact of these policies is so long lasting. In the I'd say 20 plus years that followed the Great Depression and World War II, a lot of us on the line know that the American economy grew tremendously. So when we think about things like redlining and legislation such as the GI Bill, which provided benefits primarily to white veterans, which included things like college tuition, low-cost home loans, unemployment insurance. While the GI Bill was not specifically racially exclusive, it did benefit white veterans significantly more than it did for Black veterans and veterans of other colors, of other races and ethnicities. So by the time that these benefits from the GI Bill ended in 1956, employment, homes, and college education actually surged for white people, while the racial wealth gap grew exponentially for people of color. And so why this is important is because most Americans hold the majority of their wealth in home equity and in their home equity, I should say. And the growth in home ownership during this period allowed for one of the greatest generational wealth transfers in history. So that is really important, because when we think about how this has continued today, it is the impetus for the racial wealth gap that we see in our country. And the practices and the policies of things like redlining and the GI Bill, it didn't just, I'm sorry, I was going to try to click on something, but it's not working. But it basically, it has lasting impacts. We see the vast differences in home ownership rates, wealth accumulation, and also just broad scale disinvestment in certain communities. So, redlining, it didn't only just discourage home ownership in certain areas, but it also meant that, as George Takei said in the video, that things like, schools were divested from, less banks, less supermarkets, and the communities are also more mired by environmental pollutants. So things like more freeways in their communities, processing plants. I mentioned earlier, I grew up in a neighborhood of Los Angeles that was previously redlined, and you can still see those impacts, because while there was a little portion of the community that has, upper to middle income housing, the surrounding conditions, there's a major freeway that runs through the community. There's a large processing plant or a refinery. There's a waste management plant nearby, tons of fast food, no grocery stores. So these effects of redlining are still very much present, and you can see them today. And so when we talk about how structural racism impacts health and health outcomes, I want to encourage us today to take this information and really look at the roots. The gaps that we see and the injustices that we see are really rooted in racism, xenophobia, homophobia, and you can see in this graphic that it really impacts all of these different things: employment, food access, health behavior, environmental exposure, housing. All of these things have direct impact and direct consequences on our health outcomes. So I want to just encourage us to think of the impact of structural racism. And something I didn't actually get a chance to dive into too much because of time is when we talk about racism, sometimes we think of just the interpersonal racism. So things like, derogatory terms towards one another or mistreatment. But really one of my favorite physicians, activists, describes, and her name is Dr. Jones, Dr. Kamara Jones. She talks about racism as relating to power and it being a system of assigning value for some people based on their skin, and devaluing or removing opportunity for others based on the value or based on the color of their skin and the value that we assign to that. So sometimes folks think about our individual interactions in healthcare, which is important, but we have to also take a step back and look at this broader picture that we've talked about today. So with that, I know we're getting close to time, and we have a really exciting, what I think and hope is an exciting some sort of group discussion. So we have a couple questions here about, kind of just a chance to debrief, because there's a lot I hope that I just kind of crammed into a short bit of time. So what information was new? And also because we know that adults, we take in information best by being able to reflect and practice. So, I encourage us to think about the neighborhood where you were born and raised. What types of conditions that we saw in the video were present in the neighborhood where you grew up? And what was the racial composition? What did it look like? And the third question is just, how have the places where you lived influenced your overall health? Very curious to hear kind of different experiences. And then I think we'll have a chance to kind of come back together and debrief before we hear from Dr. Singh. So with that, I'm going to stop sharing my screen. And I think we will be ready for the breakout groups.
So thank you, Dana, for Cherished Futures Collaborative. I have been working with Dana this is the second year, so about a year and a half in on the Cherished Futures Collaborative. And there is no future, right, if there's no mothers and babies. It's mothers and babies that are going to make a community. So you have no future if you don't have mother and children involved. So Cherished Futures has really opened up my eyes, my education, in the last year and a half. And as Dana said, it's very intersectional, very interdisciplinary. Multiple organizations and institutions are involved in this. So I'm going to get there, but be involved with all your community organizations. Okay, so we're going to get there. They've been doing this work for a while. And yeah, White Coats for Black Lives. I think, Dana, you had that on one of your first slides. And that's what kind of started all this, was the murder of Mr. Floyd and the pandemic. And the other thing I wanted to mention was the redlining. Dana had highlighted the redlining. So look at healthcare and think of how this applies to our hospitals. Where are the best hospitals located, and where are like the county hospitals located? Zip code dependent, right? Look at the real estate values of that housing that are surrounding these hospitals. So that redlining applies directly to our medical institutions. So do you look and see where your house is related to a hospital, right? Is it a county hospital, or is it listed in US World News Report as one of the world's best hospitals? So redlining directly affects hospitals. Where are they located and what resources they have? So that's just something to ponder on that. So we all want to make change. We all want to see what we can do. Individually, we can all do it, but eventually you need to create a team, and that's creating allies. And it's that we can't do it alone. And it has to, again, have multiple people involved. If we all think the same way, nothing's going to change. We all have to think differently. So if you have the next slide, that's in front of the Capitol building. So this is where my legislation journey had started. And this is where a few of my American College of OBGYN team members, we had started. This is obviously pre-COVID and pre-murder of Mr. Floyd. And we were kind of like a spilled bottle of syrup that kind of just about a couple hundred of us kind of just seeped into Capitol Hill to kind of help educate our legislators what resources were needed in our communities to help with the disparities in women's health care. And one of the results was SB 464, which is all perinatal healthcare workers now need bias training in California. Other states already have bias training mandatory for medical physicians, nurses, healthcare workers, regardless of where they work. So it's all disciplines. California right now has just started with SB 464 with perinatal workforce, but it's a baby step, no pun intended, so that eventually I think it's going to be mandatory for everybody to be trained in bias training. So that was one of the results that we do with legislation. So okay, yeah, rah, we like legislated. The hard work is now. Who thought we would need legislation to get to do the right thing? But we need it because, you can get a speeding ticket. You don't speed. You don't text while driving. That's why we need laws. That's why we have to do this. Because why didn't we stop this 400 years ago? Okay, so that's what I tell myself. Every single day or weekend, or when you think you need to do the work, if this was so obvious, why did we not stop this 400 years ago? So just tell yourself that. Tell yourself that, yeah, I need to do this because it didn't stop. We didn't stop it back then. And it kind of motivates you, gives you strength when you think you're like tired and done. Just tell yourself that, and it'll keep you going. So the personal story, and I'll be really brief, I haven't really shared it much. So my story was selected to share with the legislators, was my own personal story with maternal morbidity and mortality. I was a young physician over 20 years ago, and my duty at that time on that nice California summer day was to repair laceration, suture on, and a really uneventful delivery. And young, you know, physician in training, sure, do what you're told, go do it. And, you know, I noticed during that time that, you know, she was bleeding a little bit more. So I called in for help from my senior physicians, and they came in and assessed, okay, I got moved to the head of the bed, next closer to the patient. And they were evaluating her, seeing what was going on. And then she grabbed me in the most intimate way, where people aren't supposed to grab you or talk to you or anything, and said, I can't breathe, I'm going to die. And it's just a very, I can't describe it. It's just, they just hold on to you. And they tried coding her for 5 hours and she didn't make it. So after that whole thing, that was very young in my career, I always like to see, sorry, it's one of those things, even though I've like said it, you know, to legislators and stuff, it's something that kind of guides us. So I want to make sure that this 20-something-year-old child, now young adult, knows that everything was done to save their mother's life, and it wasn't because they were dismissed, their mother wasn't dismissed. There was no bias or racism involved. That's what we have to look at. There's some that's unavoidable. So what this condition was amniotic fluid embolism, very rare, but you want to make sure it wasn't due to anything dismissive or racist, right? That is why we are here. So that kind of lends itself to all the data that you see in the media, everything that we see. Why are Black women dying more? Why in vaccination rates, why is there such a disparity? All of it is combined and intertwined. And I'm kind of leaning towards another way based on our conversation today, Dana. So what can we do? Do we have that next slide? Is what we can learn.
DJ, we had 2 slides that were submitted to us.
Oh, no worries. I can get, so we have to learn, we have to educate. It's okay. It was a visual. So a lot of the part of being an ally, so that's the whole thing, is how can we be a proper ally? And a lot of people have heard me say this, is I hate being performative and I like being transformative. I don't want to check box. I don't want to say I did this training, I did that training. We want to actually affect change. And that again is being a proper ally. So if you're learning something new that you didn't know that you did was racist, I am guilty of this myself. Get comfortable saying, and I'll actually, let me see if I can pull it up here, is thanks for correcting me. I didn't realize that. It's okay to say that. I hadn't thought of it like that. I understand you now. I was wrong about that. I've changed my mind, and I should do more research before I argue that point. I am not the expert on someone else's experiences. I cannot say I'm here to fix you. I can't have that savior attitude. And all this stuff is another workshop, by the way. So all of this being an ally, how to fix everything is a totally separate workshop. But we have to be comfortable with realizing what we learned was wrong, what maybe wasn't told to us because it was just kept away from us in education. So, and that we learn from, again, collaborating with our community organizations. And Cherished Futures is one. I work with many community organizations, and I have learned from each one, you know, differently, where partnerships happen, where racism pops up and you never expected it. And you're like, oh my gosh, wow. So all of that I would recommend is really not picking one thing, but multiple things to learn from. And don't go in thinking, I'm gonna fix this, I know everything about it, because we don't. We don't. The people that have lived it do. And we have to listen to them. Those community organizations, again, embarrassing. The data has been there. It's not recent in the last 5 years. It's been there for 400 years. It's been published, but no one did anything. But then the murder of Mr. Floyd and the pandemic catapulted everything to us to like look at it because we had social media. So we were able to like kind of, now we have to go with it. Like Dana said, we have to go with that momentum and we have to push it forward and keep going with it. We can't stop. Let's make it stop after 400 years. And so that catapulted us to think and reimagine, and you see a lot of pushback. You saw a lot of like, oh my gosh, where was I? You know, kind of thing. And so the other last slide that I had was, let me see if I can get that. And it was how to treat racism like COVID-19. Treat racism, like assume you have it. Assume you're racist. Listen to experts about it, okay? Don't spread it. Don't spread COVID-19. Don't spread racism. And the last thing was, you know, be willing to change your life to end it. So be willing to wear your mask. Be willing to learn and educate yourself. So treat racism like COVID-19. So that is what I was requested to say is how to take action. And that action is through really being tired, and you have to be tired. If you're not tired, it's not working. But to look at yourself and say, what can I do that will make something change and not be just a checkbox? So don't be performative. Let's be transformative. And let's not be like a fake ally checkbox. Let's actually do something. So that's how I wanted to tie it in with Dana's work. And she's a great resource, and her collaboration is great. And they work with multiple community partners. And if anyone has any questions and thoughts and all the different places where we go, let us know. I'm still learning. So hopefully all you guys got something out of this today.
Thank you so much, Dr. Singh. It is just such a privilege to get to work with you. I'm going to share in the chat box the work that I have the honor of leading, Cherished Futures for Black Moms and Babies. As Dr. Singh referenced, we are working directly with hospitals and health systems, and I'd say in a more broad sense, to reduce Black infant deaths and to improve the patient experience and safety for Black moms and birthing people. We've sort of talked about, and I intentionally didn't share a lot of the data, but you know, it was mentioned that Black moms are dying at greater rates than women of other races and ethnicities, as are our babies. And as somebody who had a very traumatic birth experience twice, I'd say the most recent that nearly cost my baby her life. This work is deeply personal and so needed. And so, just to have the privilege of working with physicians and nurses and other champions like Dr. Singh and so many others in our collaborative is such an honor. I also just really briefly wanted to share that I did place a link to Dr. Singh's point about unlearning or relearning. And there's a really great reading list. So for those who enjoy reading, who kind of take on their own journey and their own learning through reading, this is a great place to start. There's tremendous books on here that many of which I love, and some of which I'm still, are still on my reading list. So wanted to just share that as well. I also know we were going to just kind of hear back from some of the groups about how our breakout sessions went. And so I don't know if I should pass it back over to Milia or Cheryl to kind of help us go through the different groups, but thank you so much.
Thank you so much to both of you for your wisdom and sharing the work that you do. And you're absolutely right, Donna. We were going to just do, I think you had said it right. I think for us, a lot of times for us to truly understand something, there has to be some sort of discussion about it where we can articulate what we're thinking. And so that's what's the point of the breakout rooms. And so I think what each group should have done is have someone who is going to kind of report back their findings in terms of answering those 3 questions. So I think there were 4 groups, if I'm correct. Was anyone part of group number 5 that I don't know about that can raise their hand?
No, we had 4 groups.
Oh, perfect. Thank you, Cheryl. She speaks from the unknown. And so thank you, Cheryl. So if I could ask, perhaps, I believe I was group 3. So group 1, if someone from that group 1 would like to just, share with all of us their findings in regards to answering those 3 questions.
So Dana,
And we'll
that
just
was
go
your
back.
group. Did you
Oh,
select a spokesperson?
Yes, we did, Miss Marietta.
Oh, great. Sure, I'll be happy to share. One of the things that we found in our discussion was that there was such a spectrum of experiences that we've lived throughout our lives. Not all of us have lived in the very same place all our lives. And even if we haven't come from a certain place, we may have spent time in a place where the conditions were so different from where we were raised, and we were able to observe the effects of the environment and the effects of all these different things that we've been talking about on the health of the individuals in those environments. For example, someone was on a mission in Paraguay and lived in a third world country, so to speak, and saw the health conditions that were because of the circumstances there. And I think that someone else in our group had lived in an environment where there was a mixture of races, but there was a socioeconomic uniformity. And so everyone was together in that sort of system and in that environment, and shared a lot of the struggles and challenges and perspectives there. Then later, when they moved somewhere else, they saw something completely different, and that saw the influences that were there as well. We also noted that education was a tremendous force, even though it's not the only determining factor, but it often was a significant influence in the circumstances and conditions in which people lived. And I think more than anything else, we also noticed that it's not only race, but it's often class that affects how and where you end up living and what you end up experiencing. I don't know if other group members wanted to add to that, but those are the things I know we all took away.
Thank you, Marietta. It's interesting what you talk about the class, and I think, Dana, you said it. It's not just, it's a power, right? It's all power dynamics, and that's what it is, and that overshadows all these, the race, ethnicity, color, it's power, and I think that illustrates it beautifully. And I would love to know what place where everybody lived socioeconomically. That it sounds like utopia, and I think we would all love to learn from where that place was. Group number 2, who do I have from group number 2?
That's DJ.
Oh, DJ.
Yeah, we were there, and I'll have Dr. Wynn chime in a little bit too. We kind of realized we didn't know we were so segregated in all of this growing up. We were just like, we weren't educated. And now at this current time, we realize, and being more hypervigilant about racism around us, that, wow, it was around us even when we were young, but we were just not looking at it. We were just kind of going with the flow. And that's kind of like all of our stories. But if Dr. Wynn is still on, he had his story and his impression, if he's still on.
I'm still here.
Okay.
Yeah, no, it was fascinating to see. Even as a group, we came from different backgrounds, and we still live in a variety of locations within the South Bay. So it was kind of interesting to see how we still are from different areas, but we all came to the same sort of feeling that when you live in that environment, when you live in an area. And we all came from humble beginnings, that you don't realize that what you're missing out on, and it's only until you start seeing what other places look like that you kind of understand what was lacking. And so for myself, I grew up in the Inland Empire. I'm still going to use Inland Empire. Apparently, we're supposed to use Inland Region now. I grew up in the Inland Empire. And growing up, I didn't think anything different about it. But now living here in the South Bay, I can see that, I didn't have access to community parks. I didn't have access to local trails where you can go for walks. You didn't feel comfortable going for walks late at night due to safety issues. And that is definitively an issue to one's health, right? And then you talk about pollution and smog levels and things like that. And so it goes beyond just your local environment, but what you have access to. And that is all detrimental to your health. And then the point that Dr. Singh made with, just thinking about local hospitals, obviously, the zip codes where the top tier hospitals tend to be in ritzier neighborhoods, and you go to other neighborhoods and you don't get quite the luxuries of the top tier hospitals. So it was interesting to see that come from different perspectives.
And Dana, we created the orange lining for Halloween. You go to the neighborhood that, doled out better candy. So we called it orange lining for Halloween. So that was, the disparities right there.
It's a microcosm of what's out there, right? The orange linings, microcosm of the red lining that happened throughout history. And one would argue is still happening, right? And whether we acknowledge it or not. Thank you so much. Thank you both for your sharing your group's findings. Group number 3 was my group. And I believe we have Ron, who was going to share. Ron Nelson.
There I am.
Oh, there you are, Ron. All right.
In our group, we had our own diversity. Two of you were from immigrant families, whereas my immigration was from El Sereno to West Los Angeles to Long Beach. Theirs was from Cleveland and in the Midwest. And I think all of us had a somewhat limited family incomes that we came from. And so we learned about different kinds of people in those different neighborhoods. And now we're very much aware of the differences in the various neighborhoods we live around now. And it can be a very short distance from a very affluent area to a lower income area. And the resources that are available in those areas are very different. Even though I lived in 3 and 4 different areas of Southern California, I always lived where there was outstanding hospitals and doctors. And so a lot of this whole conversation has been new to me.
Thank you, Ron.
Anything you add, Amelia or
No,
Sarah?
that was great. Thank you, Ron. I think Sarah and I had similar, you're right, coming from immigrant backgrounds. And we were talking about how, it was very difficult financially for our parents when they first came here. And that directly reflected in terms of access to food, right? Not simply because we couldn't afford it. And Sarah brought, and I'll share this point from our group. Sarah brought in an excellent point that, it's not just about just the food, but your access to education, also the overall arch of stress, right? Because that's a huge thing, and all those influence stress, and then stress then in turn influences the health, right? And we were talking about how we see it black and white in our parents now, right? These parents that a lot of the immigrant generation that came, that first generation, the amount of struggle going from nowhere to providing for their kids and things like that, it's a direct correlation insofar as how their health is right now. So it's so intertwined, and I think that's what Ron was stating from our group. Thank you so much, Ron. And I think our last group number 4, who do we have from group number 4?
Steve, me.
Oh, hi, Steve. Reverend
Hi.
Steve.
Howdy. So we just had 3 folks. We had, I'm from the Boston suburbs, which were primarily white with a sort of like some, mixed Asian folks, relatively affluent area, not ridiculously so. We had Winnie from Davenport, Iowa. And that sounds rural, but it was more urban than it sounds. And then we had Susan, who's a Long Beach native of sorts, and kind of mixed neighborhoods that, working class kind of neighborhoods of mixed color. And Susan shared stories about her husband who had different experiences in the same kind of county hospital story, right? You sort of where the hospitals are. I think my reflection is more that, the neutrality of not thinking about healthcare is its own privilege, right? So I didn't really have to think about healthcare or, we were pretty working class, but I never didn't have a doctor. that was always pretty close. I had family around. So I think we talked a little bit about food deserts. We talked a little bit about the disparity in birthing practices. Winnie was an OBGYN and has sort of some history in that world. Talked a little bit about formula coming into hospitals and how maybe the heritage, the legacy of Black women nursing babies sort of led to increased use of formula, and there being stigmatisms in that area, and just like a distrust of healthcare with, the Tuskegee experiments, and, a couple personal examples were shared in that avenue. Nothing groundbreaking, but kind of reinforcing that same kind of class, race spectrum of inequality and how that hits healthcare just like it hits education and every other aspect of, that leads to one's well-being. So there we go.
Thank you, Steve. Thank you so much. And I think that was all the groups. You talked about Boston, Steve. I was telling in my group, I grew up in this small little town in the Midwest, Fulton, Missouri, 10,000 and growing. And my brother's practice is still in that town, right? Which is crazy. And I'm in the Midwest right now. But what was interesting, I was talking about Boston, and this sounds crazy, but Boston was the first, when I was in Cambridge, and I couldn't afford living in Cambridge, so I lived in Somerville. But when I was in Cambridge, that was the first time
afford to live in Somerville.
Huh?
Now you couldn't afford to live in Somerville.
Now I couldn't afford to live in Somerville. There's no way. Yeah. But it was interesting because it was the first time that I saw kale packaged so like luxuriously and sold for such like $12, $13. Like, what is this? But again, it we joke about it, but really it's a direct correlation to the community and where we were versus where I came from. And so it really was a very black and white, no pun intended, example of it matters, that what you're talking about, Dana, the zip code, absolutely it matters insofar as what's there, what you have access to, and the overall well-being of an individual. So thank you all so much for sharing what you found in your discussion groups. And Dana, please take, yes.
Yes, sorry. Obviously I love, this is my life's work, so I'm always excited to talk and share. One other thing that I just wanted to share with the group, and I'm going to put the link in the chat, is there, Dr. Singh had talked about SB 464, which was a training requirement that went through and passed, I think it was that was 2019. I just wanted to share with the group that there's quite a few pieces of legislation right now in our California state legislature that are progressing. And one I just wanted to point out to the group is SB 17, which would establish an Office of Racial Equity. And has some really cool requirements, data requirements. I didn't put the link to the bill text because it's really dry unless you're into that like me. But I put a link in the chat to something that's a little bit more accessible and kind of talks about what the legislation is. So, for those who are active, I see Richard, your background. So for those who are active and like to advocate for different policies, this is a great one that is, going through the process and we hope will be signed into law. So yeah, keep an eye out. There's a lot of great policies moving forward here in California.
Definitely a process, as Dana said. So it's not like I said, showing my picture, hey, I lobbied. It's not about me. That's centering myself. We don't want to center that. We want to center the work and the process. And the hard work is now after that legislation gets passed. There is hard work with legislation, but everyone has their niche, their strengths. And that's why we all work together in all different realms of our lives to make this happen. Everyone here in this chat on this screen is working together right now. So that is how we affect change.
Right, absolutely. I know on our program agenda, Sardine, are you still with us? I think we might have lost you as your.
I think she had to, she lost internet, so she dropped off.
Sure. Okay, no worries. Well, I know that we wanted to spend some time if there's any questions from just the participants in the audience in for Dana or DJ. So at this time, we would love to open that up if you want to raise your hand or just, speak out. That would be great as well. So any questions for these two dynamic women that we have with us? Should we give a
I
quiz
might
so that we
comment.
know? Oh, Ron, yes, please.
This has all been new to me. Some of the terminology you all use, I don't even know what you're talking about. The things that you're dealing with, I was clueless about. And as I think of my congregation and my church and in my denomination where I'm really involved in the justice team and social action, I would think that's probably true of most of the people I know. So I appreciate hearing from you because I was totally unaware of it. Thank you.
Ron, thank you for saying that, and thank you for, I think it's something that I jot down notes during these presentations, and I think it was DJ that said that, that we have to be comfortable with acknowledging that we didn't know, that we didn't know, and we need to know it. And I think that one of the reasons that we were really passionate about this Dr. King series is that we wanted to present these programs as a faith community, but we also wanted to show that, hey, there are these really amazing people in our communities that if your congregation, if your mosque, if your synagogue, if your temple, if you want to engage in this type of a conversation, then there are people available that would be more than happy to do so. And if you look at it from a purely theological perspective, I mean, embedded within whatever faith we are, there's a sense of the topic of justice is central, right? And at the end of the day, this is about justice. This is about being sure that we are acting in a just manner with all of humankind and not just the privileged or not just a group. And so, I don't think there's any question that it's something that's definitely advocated by our different faith traditions. But oftentimes, and Ron, thank you again for saying that, we don't even know that we don't know. Right. So I encourage everyone who's here, if you, Ron, if you are interested in having a program like this in your faith community, please let us know. That is why we are here. As Dr. Singh said, and as Dana said, it's about connecting with resources, connecting with organizations, and spreading the word, and 1% at a time. So thank you again, Ron, for sharing that. Any questions, thoughts, concerns, comments, please?
Oh, I have one. I had my little hand raised, but I guess I'll just say it out. Can you tell us a little bit, Dana or DJ, about an area where you've seen perhaps the most progress or some positive changes regarding this? Is there anything that stands out in that realm?
Ooh, that's a big question. I would say we've seen progress in pockets. So in the work that I do, both with working with local county governments and state governments, we tend to look across the country for best practices and seeing what people are doing. And actually, we recently did a COVID-19 vaccine video series where we interviewed different leaders from different parts of the country. So St. Louis, Utah, just looking at how they were reaching disproportionately impacted folks and communities. And I'd say even in that process, we've seen such amazing transformations of how folks are partnering with community partners, with government agencies to vaccinate, to create more access. And so there are a couple places that I'd say are some of my favorites. So Seattle King County is doing just incredible work across the board in terms of how they are advancing racial equity and justice. They have kind of been a leader, a national leader, and have really made some amazing strides. But I even say here in our Southern California region, we've seen a lot of great progress. And sometimes progress can look like the process of what you're doing. So the process, I think it was Miss Winnie who said in the chat, like, that there are other parts where, like in Wisconsin, where some of these wouldn't even get to the conversation phase. So the fact that we're willing to name it, that we're willing to name racism as an issue, and people are starting to put the words into action, dedicating, money and resources and budgets and all the things. So to me, that's even progress, is like the fact that we're seeing so many places that are actively trying to undo the decades and decades of harm that have been done. And I think it'll take a lot more time before we start to see, quantifiable numbers or shifts or closing some of the gaps on a large scale. So to me, I'm always really heartened by the steps that I'm seeing large institutions and different government entities taking. Dr. Singh, did you have anything to add to that?
Yeah, no, progress is just look at Ronald's aha moment today with the terminology. So that's a great success story right here today. And we do this everywhere with different hospitals and institutions in our workshops. And it's just getting that aha moment. So that one person now is going to go share that with someone else, and that person gets it. Some will get it, some won't. And like legislation, slowly working with SB 464, even when we're trying to teach physicians and doctors are like, well, why do I have to take it? I'm not racist. I treat everyone the same. But the data is showing this, so we have to do this. And then it's introducing them to the terminology and what they didn't see. And so that's where you get the little wins, I guess, the progress. And where then we get to hear what we didn't hear growing up.
Thank you, Marietta. That was excellent. Anyone, any other? I think Steve, you had your hand up. Yes.
Yeah, it was just, Ron's kind of aha moment of I didn't know this was going on is, I think it's actually a little bit, not to use a bad phrase, but I think it's darker than that, because I think that in my family, which were just your classic, quietly polite, racist white people, I think we wouldn't have never said it, but I think we would have not cared that much. It's just that it's not that we would have ever said that, we would have never said black people don't feel pain or any of these sort of stupid things. We would have just not thought it equal to a white family. Without ever saying it. We wouldn't have articulated that, but we would have just sort of thought, okay. And I think that's just a greater truth. I mean, that's the harder truth, and that's the sort of, as I think it's Cornel West or somebody says, it's what you don't talk about that matters the most. And I think white people are starting to be forced to think about what they don't want to talk about. It's true.
And you being an ally, Stephen, is that, they may not want to hear what Dana and I say, but they will listen to you. And it's just, that reflects that bias. So like I said, it takes everybody to affect that change.
That's such a good point about what you just said, Stephen. And I think that is part of the challenges to why we see this progress being slow, is that it's kind of like, meh, we would never name it, or, how does this impact me?
Yeah.
Or, it's kind of just not out. If it's not in our view, then it's kind of just easy to ignore. So yeah, that's such a powerful statement of what you said. Thank you for sharing that. And I think that's probably a sentiment that's shared very broadly. So I appreciate that. And like Dr. Singh said, it's a ripple effect. Like, folks talk to people in their own networks and then it grows. That is the hope.
Yeah, we had General Assembly in the UU World today, and there was a joint service that we watched virtually. And in one of the prayers was this line of, where hatred meets not my problem, that's where things grow. It's like where that just a little bit of hate grows into, not my problem. there's a forest fire of indifference that can just form. Sad but true.
So I'm gonna share a story of what I've been through recently that'll lead into a question. I mentioned at the beginning that I broke my leg pretty bad, had major surgery. I've worked in the health field, so I know how to work healthcare plans, even when I don't have a great one. And because of the break and because of history of having a bone tumor, I had to go to a specialist. So my doctors were at UCLA. So I had the privilege of checking myself in. Pretty much the health plan was dragging their feet. So I went to the emergency room at UCLA in Santa Monica. Had I not known, I dragged around with a brace and pain pills for 8 days before that, knowing that I had a major had going to Torrance Memorial emergency room and then having to keep waiting for authorizations for the orthopedic and then the trauma specialist and then the orthopedic oncologist. And I will say, if you ever have to go to the hospital, go to that one in Santa Monica. They have room service from 7 a.m. to 10 p.m. They have aromatherapy. They have all kinds of wonderful things, and you have palm trees outside your window. But had I not known how to work my health plan and not had a doctor like I did within my oncologist who directed his care manager to say, hey, go to the emergency room. Don't tell him you talked to us. Go to the emergency room and say you're in pain, because then your health plan has to admit you, and then you'll get surgery right away. And what that leads me into is what my good friend Dr. Rich has behind him is AB 1400, and hearing the stories from him as a doctor, hearing Sarah's husband as a doctor, have two patients presenting exactly the same and having to prescribe different medications that might not be as effective or therapies. I'd like to say that, I saw so many doctors in the hospital, and every one of them I said, we need single payer health plan. And the only one who did not agree with me, and the nurses were on board, the only one that didn't agree with me was my orthopedic trauma surgery, who makes a lot of money, obviously. Yeah. And he's like, oh no, you would have had to wait even longer for your surgery. So I think that's something that we can all do, because the doctors and the insurance companies are going to be the ones who oppose that. And so kind of handing it off to Dr. Rich and Dr. Singh, what are good messages to tell our doctors? I was, waiting to go into surgery when that doctor told me that, so I didn't have any good comebacks. But I think we need to learn to talk to our medical professionals to break down those barriers, to make them realize that our healthcare system is so inequitable, and the only way that it's going to become equitable is through single payer.
The payers are very powerful lobbyists. United, Anthem, Aetna, they rule the world. They control it. Payments, authorizations, holding back therapies, holding back treatments. That has to be more regulated, absolutely. They're underregulated. So Dr. Nguyen has been, one of the people you've been talking to about, the single payer. It's, again, a lot of undoing stuff that's been done for years and years, and we have to deconstruct that and undo that. That's the hard part of it. It's like when we have patients coming in that are supposed to deliver at a certain hospital based on their insurance plan, but they know it's going to be better at, Torrance Memorial or UCLA, then those payers know we don't have to pay if they go out of network. And it's a whole mess. That's another workshop again, right there. So.
Wow, thank you, Susan. I know, Susan, we felt like we took that journey with you, minus the actual physical pain, because Susan is the president of the Interfaith Council, and so she would keep us updated, as Dr. Singh is a member of the board as well. And so we're grateful that at least you're in a position now where, although still uncomfortable, the work has been done to repair your leg. So we're grateful for that. I do want to be cognizant of the time. It is 4:50, and I know that we had said that we would end at 5. So if just first and foremost, thank you so much. Thank you so much.
We did have one more question from.
Oh, we did. I'm so sorry. Who was that, Cheryl?
Dr. Nguyen.
Oh, please, Dr. Nguyen, please.
Yeah.
Thanks for first and foremost, I want to say thank you for this wonderful discussion and this wonderful topic that needs to be said. And thank you to Dana Shroud and Dr. Singh for speaking, because just a wonderful presentation. I was going to ask a question, but I wanted to sort of give Susan an answer to her question as to how do we approach that conversation with physicians and whatnot. And Dr. Singh's absolutely right. The lobbying power of insurance companies, these health insurance companies, is tremendous, and they have sort of created a narrative that a lot of physicians and a lot of people have come to take, but the reality is it's all misinformation. It's all very untrue. And you're right, the system is broken. And much like many other systems within our country, it is rooted in racism and rooted in keeping the power structure the way it is. And it maintains that power structure. And so, as Dr. Singh says, we have to break that down. The system right now is a convoluted mess. Multiple payers, secondary insurances, Medicare A, B, Part D. What are we talking about here, right? It's a complete hot mess. And then when it comes to billing, on the billing side of things, it's a hot mess. We don't even know where our money is coming from. Like, I don't know how I'm getting paid. I don't know where that money is coming from. It's because they create this convoluted system to make it difficult for us to understand and for us to break down and for us to understand where the money's coming from and whatnot. And that's why single payer system truly makes sense, where it's literally from one source going to one facility, and then the care goes to the patient, and it's a straight line, and everyone deserves equitable care. Everyone gets care from anyone. And so that's what you kind of have to break down to physicians and just say, like, well, how would it make anything different? Why would it make it different? Ask them the questions. And most of the time, most physicians who answer negatively towards single payer, it's because they don't know any better. It's because they don't know the answers to those questions. And when they become flummoxed, then they'll start looking up those questions themselves, and they'll realize, maybe I was wrong.
It doesn't even, it's not even that complicated. You have an entire industry based on not paying bills to people who pay you premiums. That's it.
Bingo,
That's
right
it.
there.
It is an industry that completely doesn't even need to exist.
It's a racket, is what
It's a total racket.
Thank you so much, Dr. Ren. Thank you for addressing that. And thank you to Dr. Singh, to Dana, for all of you for being here and being part of this conversation. I believe it's Reverend Steve who will be giving our closing invocation, but one of the things as I was hearing all of you guys and writing down the notes, on our flyer, we had this quote from Dr. King, right? And he said, "Of all forms of inequality, injustice in health is the most shocking and inhumane," right? I mean, and it's true. I mean, it's heartbreakingly true. And so the fact that we were able to gather and engage in this conversation, the fact that we have such dedicated healthcare workers, Dr. Singh, Dr. Wynn, Dana, for all the work that you do, thank you so much from the depths of our hearts. And we thank you for your commitment. We thank you for your work. We thank you for continuing this struggle. It wasn't done 400 years ago, right? What Dr. Singh said, but we have to make sure that it's done come for the next 400 years. I wanted to I always do this kind of at the end, just recap some points so that we go away with something. There's so much information that's shared here, and I want you to know that this will be available on our YouTube channel as well. So please revisit this conversation and please share it with others. Ron, this is a great conversation to share with your members of your church and clergy and whatnot. But one of the things that Dana said in the very beginning, zip code is more important than our genetic code, right? To remember that, because that's one of those things that we don't often think about. And with Dr. Singh, talking about how we have to be comfortable with acknowledging that we're wrong, that acknowledging that we don't know, that's a huge first step. How listening to that we don't know everything, that there's others, there's Dana who's devoted her life to this work, and she knows infinitely more than I will ever do, and how we're lucky that we have that to engage one another in our community and organizations and individuals who are working on this. I loved what you said, Dr. Singh, treat racism like COVID-19. Assume you have it. Assume that you have it, because invariably you probably do. Implicit bias, implicit racism exists in all of us. Don't spread it. Don't spread it, and be willing to change your life, you know, to protect others from it. It's brilliant. You're absolutely right. That's how we should do it. And I think the last thing that I just wanted to say is that call to be transformative. But at the same time, I think Dana in the beginning, and I noted this down because I was like, you know, this is great. A lot of times it can be hard. Like, really, are we making a difference? You know, is this gonna, I mean, is it gonna change in my lifetime? I don't think so. But I go back to what you said, accept non-closure on long-term issues. The work is ongoing, right? But the work has to be going, and that's where it includes all of us. So that was great. Thank you so much for that. Before I give it to Steve, Cheryl, I do want to ask you, if I may, to pull up a flyer that we have, and I hope that you guys can all join us for this as well. And interestingly enough, Dr. Nguyen is one of our COVID heroes that we are honoring in this gala, which the flyer is coming up. We have our third annual Interfaith Gala on July 11th, and it's on Zoom. And this year, part of the gala is we really wanted to acknowledge these COVID heroes. You know, these individuals. Dr. Nguyen, for those who don't know, is a pulmonologist, and the stories I've heard about him, I can understand why he came so highly nominated for this position. Cheryl, do we have the flyer by chance? I think we're working on it. Okay, it's coming up. So it is July 11th. It is online. It is free to the community. It is a time for us to just come together as people of faith, as people of different cultures, and just be in fellowship, in celebration with one another. And also a time when we honor these individuals. Cheryl, were we not able to get the flyer? Here we are. There we go. Yay. Okay. So yes, so our third annual gala celebrating the awakening of human connection, Sunday, July 11th, Pastor Q, who's a phenomenal individual in his own right as well, who has the Road Church, the Church Without Walls, which is on Skid Row in LA. He will be our keynote speaker. COVID heroes, like we said, Dr. Nguyen is one of them. We are honoring also local farm workers, farmers, teachers. We're honoring a music therapist who actually lost his life to COVID posthumously because of the work that he did, as well as community members who are doing work to help the neighborhoods, to help our community, those who need it the most. We'll have music and dance, the Zainab Ensemble, Arabic poetry and in song, Pacific Islander music and dance, the Stanford Bhangra team, Rolling Hills UMC Handbell Choir, as well as the Jewish Community Children's Choir. So we really invite you to please be a part of this, and we encourage you to please spread the word so that we can just join in fellowship with one another. So that would be really great. And so now, again, thank you all so much. Thank you for the committee. Thank you for Cheryl, who oftentimes we don't see her face, but she is the voice and the work behind everything, who is our right hand. Thank you, Cheryl, for all that you do, our office administrator, the committee, the board, and thank you for all of you who joined us today, and most certainly our presenters. So before we conclude, Reverend Steve, I'm going to ask you to please offer the closing invocation.
Sure. Let's bow our heads and fall into a still, quiet place. You know, before there were gods that we prayed to, there is the human experience of suffering, being sick, feeling fragile. We all know what that feeling is like. And I just ask us to think about the inequality of how that is dispersed across the globe, across different peoples of color and culture. And as we think about our life's work, we think about the way we want to spend our time. May some of that be dedicated to ending and the inequality of suffering, some of it inevitably necessary in dying, but think of our role in making that more.
So Esty was saying, let's just bow our head and let's just be silent in contemplation. And let us be grateful for the fact that we're able to gather here to get together as people from diverse faiths, as people from diverse cultures and backgrounds, ethnicities. And let us be grateful that we have been granted an opportunity to make change in this world. And let us always remember that the change that we make, even if it's small, that it is something that is important and that it matters. Let us never lose our motivation to make that change. And let us always create a society in which everyone is honored, in which everyone is respected, in which justice prevails to every person, every human being, regardless of their faith, their color, their ethnicity, their sexual orientation, regardless of anything. But rather, let us always remember that we are human beings and that unites us together in humanity. And with that, let us continue the work. Let this program be a catalyst in encouraging us and in motivating us and in allowing us to continue the invaluable work and let us be an agent of change in the society that we live in. We thank you so much for this gathering, and we wish all of you the best, and may God and one who is called in so many names and understood in so many ways, may he be the one that always keeps us united, and may he be the one that allows us to be this agent of change in the societies that we live in. Amen. It's not as good as a pastor, but it's the best I could do at this time. So thank you all so, so much. Know that this will be on YouTube and you'll all get a link to that. And thank you again, Dr. Singh. Thank you again so much, Dana. And thank you to all of you for being here. Have a blessed evening, and we'll see you next month when we have another program in our Dr. King's series, in his dream series. So have a good night, a good evening, and we'll see you soon. All right, take care. Thank you all so much.